Hello and welcome back, everyone, to our Shaking It Up podcast. I am Maria.
And I'm Vicky, and today we are joined by a very special guest, Rachel Rutley. And Rachel, you're going to talk about dystonia and Parkinson's and what it is and how it affects people and what we can do to help it.
So, Rachel, thanks for joining us today. So can you start off by just telling us a little bit about yourself, about how we know you, and also about how you came to focus on Parkinson's and particularly on dystonia?
It's very nice for you to have me. Thank you very much. It's very exciting. Nice to have a chat as well about something that I am a bit passionate about and a bit nerdy, really. I'm a physiotherapist. I've got a lot of years of experience, and I also work as a clinical academic at Keele University in Staffordshire. It's really interesting. When I sat down to think about this, I realised that my experience with dystonia goes right back to the mid-1990s when the very first Botox injections were being done. And I worked at the National Hospital for Neurology and Neurosurgery in London. And my wonderful boss, Sue Edwards, was bringing me the people that had had Botox to have physiotherapy treatment. And it was very new. So I actually worked with people with generalised dystonia. I worked with people with cervical dystonia, not particularly Parkinson's at that point. And then I kind of realised that I've come full circle with this whole dystonia journey. We started noticing, I was working in a clinic in Cheshire, and we started noticing funny feet with a few people, and a colleague asked me to look at someone, and we started checking everyone's feet and came across foot dystonia. So we can talk about that in more detail, but then I really started looking at dystonia again. I have continued over the years occasionally to see someone who has dystonia, not without Parkinson's. I kind of have both sides of the experience, and they're slightly different, which has been really interesting as well. So yeah, it's all very exciting.
God, that's so interesting, isn't it? Really fascinating. And I guess for some of our listeners out there who aren't familiar with dystonia, I mean, how would you describe it in sort of simple terms?
Yeah, I think people feel dystonia as kind of uncontrolled muscle activity. So they might be felt like a bit of a spasm. If it's quite mild, it might feel like a cramp. But sometimes people have full-blown movements that are occurring that they're not really controlling. Obviously, they're coming from somewhere in their brain, but they're not able to control them. And so there can be a lot of excessive movement. And it's a bit different to, like, people with Parkinson's have dyskinesias, which kind of look similar. But in Parkinson's, people tend to have like cramping, and I've seen a lady with terrible dystonia in her neck muscles, and she had lots of pulling back of her jaw, and it can be quite painful as well. So yeah, challenging.
Yeah, really, gosh, it sounds really, really challenging. And in fact, it seems to me from people I've spoken to and people I've seen as well, that dystonia seems to be in Parkinson's seems to be more common in people with young onset Parkinson's. I was at the Ray Kennedy Cup last weekend before last, which is the European Parkinson's Walking Football Tournament, which happened to take place in Cardiff. And it was lovely to meet lots of people all over Europe who are football fanatics, doing their walking football and living their best life with their Parkinson's. But there were a number of people there, a number of people, of the footballers, who were talking about their dystonia. I was asking them about it, and they were saying, certainly within the people they knew in their group, these tended to be people with young onset. And they said, we've noticed that this seems to be a common occurrence in people like us. Is that true?
I don't think so. I think this is something that needs a lot of study. So I've done some research into dystonia and desperately trying to write it up for publication. I think it's in the literature as it is at the moment, particularly the foot dystonia, so the dystonia in the foot, and particularly that one that comes on before people are medicated. And there are different, there are different types of foot dystonia, so it is a complicated field. In the literature, it's only really documented in young onset, and there's a few cases. There's not a lot written about it. And the cases talk about people who are younger, and you meet people who have, that's their initial symptom, their presenting symptom, which is a foot that catches on the floor because it's clawing and catching. But I've seen that symptom in people who are older. I've seen that in people who are post 50 at their diagnosis. And I think it is a slightly more complicated, but also a more prevalent condition. So if somebody is, if they're a bit older and their foot is just cramping a bit, everyone would put that down to a balance problem. They wouldn't necessarily say, oh, you've got a bit of tension in your foot, because actually the two are really similar. And I kind of think we can drill into it a bit more, but I really think that probably is the origin of it. But when someone is younger, it isn't as impactful on their balance. It's just feels a bit funny. The foot catches it. You don't have full lift up of the toes. So I think there's some really nice work to do on it as well.
That's really interesting. So would you say, before I was diagnosed, when my foot dragged, which was one of the early signs that my husband said on a dog walk, why are you dragging your foot? Pick it up. Yeah. That would be. So that's might be. Yeah.
It could be. So if that happened, you can have, so if you've got dystonia in the foot, then the muscles at the bottom underneath the foot are kind of clawing and holding. And what that means is that your foot doesn't have a normal interaction with the floor, which is required for us to create the pressure that makes us move and move normally and use all of our normal movements. So if the foot isn't working properly, then often it will do all sorts of things. You see people that swing their legs round, the foot doesn't lift, you don't get that normal heel going down as someone steps, and that can be a foot dystonia. I've met several people that's their first symptom.
Yeah, it's interesting. Are there any other particular areas of the body that are affected first, or movements?
Yes, so you can have dystonia in lots of different places. I mentioned somebody I'd worked with who had it in their neck, jaw, like I've seen that in several people. Some people have it in their trunk, so in their middle. And they have kind of a little movement. You might have heard of camptocormia, where someone ends up with a bit of an angle, and that is often a dystonia in the middle. I've certainly worked with people who've got that. There's been some really interesting write-ups in the literature about camptocormia being linked to a dystonia in the trunk. People have it in their hands. I mean, you can have it in all sorts of different areas in the body. And some people might have dystonia in multiple areas, other people just in one area. I've seen people early on where we've detected a thing going on in your middle, and a client who had a scoliosis because they were young onset, and that was one of their initial symptoms. The other complicated factor is that then the other types of dystonia and Parkinson's are people that have it in relation to their medication. So you've got unmedicated people who might have it as an early symptom, but then most people are put onto medication. And then you've got a post-medication, different type of dystonia, which then again can occur in different parts of the body. You could get it in the foot. I think it can be managed, but it needs to be looked at. And that will be, some people have those, again, it just gets so complicated, but they have off dose, so maybe early morning before their medication, but some people have it as a peak dose. So what we're really saying overall is that actually your brain can do weird things at different times of the day, and you might have a variation in that dependent on your medication as well.
That's fascinating. It is really fascinating to hear about different types of dystonia that comes earlier on, later on in that journey, dystonia that's just is there pre-medication, but then can appear once you start medication as well. So I think it must be such a huge challenging thing for people to live with in their everyday life. Could you give us a picture of the kinds of challenges people must face day to day, Rachel, with this?
Yeah, because if you start, if any of us started moving in a way that we weren't doing before, then that's going to be weird. It's quite disconcerting. So there's often a reaction to that as well. So someone might be trying to conceal it or, move in a different way. You see this with people who maybe don't have very good posture and put their hands behind their back to try and help them stand up straight. Well, the same thing can happen with any of the dystonias. So people can feel very weird. They can feel very self-conscious if they have extra movement, and it can be very anxiety provoking. And then anxiety makes lots of neurological symptoms worse. And that's a real problem then, because if people feel like absolutely wrongly that they're making things worse because they're not on top of it can become a really nasty spiral and make people feel that they're out of control, really. So that's not good at all, and very, very difficult for people. It can affect their mental well-being, really negatively.
Yeah, that's what I was thinking about. It's not just the physical effects, it's it's the non-motor symptoms. I mean, how can it affect their total well-being? What can it lead into depression and areas like that?
I think anything that, if people don't understand their symptoms, one of the things that I do as a clinician that I think is really important is that people understand their symptoms.
Yeah.
I think people need to know what they're dealing with and what the impact of them is, because then they can work with them to reduce that impact and then, keep them at bay. The worst thing is to kind of go, that's horrible, let's just ignore it and carry on, because particularly the dystonias get worse, and the potential for them to worsen is massive. And actually it's something that I'm really passionate about, having people understand and then seek the right support to manage it, because they can be really well managed as well and improved, and people often don't get that message, so they just think they have to live with it as well.
Some people seem to not know whether it is a dystonia or whether it's just like cramping, especially if they're people who are exercising hard for their Parkinson's. Is there a way of working that out?
Yes. When I assess dystonia in their foot, I'll look at the difference between the 2 feet. So it's really usually very clear that it's on the Parkinson side. It's provoked by weight bearing, which is why then you get that problem with the foot catching. So on increased weight bearing, particularly into the forefoot, usually you'll see toe cramping and clawing. And so lack of acceptance of that foot on the floor, and you won't see that on the other side. And so you could say it's like a balance response, an abnormal balance response. If I can't stand on one foot, well, I'm going to hold on really, really tight and claw. And it's like that sense of falling, but it can be retrained. So, you need to be aware of what you're dealing with. So if you compare it with the other foot, and one foot actually behaves quite nicely and the other one doesn't, then you're likely that it's a dystonia.
Absolutely fascinating. So what can be done about it? Usually, what sort of treatments are out there for people with it?
It depends what the response is. So it'll be different in different parts of the body. If we look at the foot, which is kind of easier to illustrate, if someone is standing on their foot and they have more weight towards the heel, the foot is quiet and not toes aren't clawing, and if they put their weight onto their toes and then the foot claws, then often you can just retrain that. You teach them to grade that response. So you can retrain a lot of things in dystonia. Even people that don't have Parkinson's that have dystonia, we do lots of retraining. Then we can look at sensory input. So there's a lot of research that says that people with Parkinson's have abnormal sensation in different places. So might not know quite where they are in space, or not have the information that comes from their joints integrated effectively. And I think that's a big part of what's going on in the dystonia, particularly the anti-gravity dystonias. Anyone that has something that is okay when they're lying down, so even a camptocormia or a truncal one, and then when they stand up, they have a response, then you can retrain sensation into the periphery, so into hands and feet. You can also desensitize that spasm that's happening in any particular area with sensory feedback. So I use foot rollers, but kind of quite discreetly with people. I get people to use maybe a golf ball into really tight muscles that have been tight over years or over a longer period, months, it doesn't even matter. But we use a combination of desensitization, stretching, really releasing those muscles, sometimes through treatment as well. And that really helps, like massively helps. So those kind of early onset, particularly young onset, that helps massively. If someone has a dystonia that's related to their medication, then they are also treatable, really treatable. But you have to really look at the movement that's happening. So people might have a lot of twitching, a lot of movement going on in an area, and using sensory feedback. It could be different sensations from, say, furry or something that's rough, but different types of sensation. You might re-educate movement with someone with a bit of information, and all of that helps the brain to calm down. Because overall, dystonia is the brain almost, I always think of it as like kind of overdoing the neuroplasticity. So it's trying to create a solution to a problem that is there, but the solution becomes part of the problem because it's just too much. It's not graded enough. And somebody's, if my arm was moving all over the show or my body was moving, that would make me quite stressed. And so that would feed into the negative response. So it's about really peeling away all the layers of what's going on gently to then get people back to some really effective movement. And the final way of really joining the dots to treat dystonia is to have improved function. Yeah. So if it's in someone's feet and they can't get their feet to the floor because they're moving, then all the things that I just suggested, and then feet on the floor and graded weight going through the feet, and then graded rising up against gravity. So it is really treatable. It's technical and it takes time, but I have really seen good responses from people when we've treated it.
So there's a lot then in the non-medical approach then. So what you're saying is things like physiotherapy, exercise, occupational therapy, all of those sort of things might, and presumably it depends on the individual.
Yeah, absolutely. Yeah. I do think that there's a big place for Botox. So for anyone that is having like really tight responses and they're unable to release any of the tension, or it's maybe, well, in any area, actually, there is no one area that I would say was preferable to have Botox than anything else. I'm a big believer in exercise and stretches post-Botox, because just because you switched off the actions that are going on, like the extensive non-stop actions in a muscle, say that's firing dystonically, you need to realign, so you need to stretch that muscle, you need to re-educate the other muscles around it. So if you can switch off a response by giving it Botox, which is great, it only gives you a window of 3 months to get into that area to re-educate before all of that comes back. So there's a lot that you can do with therapy in between.
That isn't your face. Unless that's injecting, just so everyone's clear and may not know about the Botox, that's injecting into your foot. Okay. Just in case people don't know.
Absolutely. We could have a whole other conversation about what happens to people's faces over time with Botox, because you could see it.
So you're saying that, so say in my foot, if I have Botox injected, there is the possibility after a period of approximately 3 months that might improve.
Well, it would come. So after 3 months,
it would improve straight away, wouldn't it? But
it improves.
Yeah, it improves. Yeah. So the muscles stop working within 10 days, 2 weeks. Wow. 10 days, really. Yeah. We normally say after Botox, and it knocks out the connection between the nerves. Yeah. But those nerves are still trying to fire from your brain unless you give them a reason not to.
Yeah. Okay.
So I've worked with people where after 3 months they don't need the Botox again because they've made such good progress with everything that they've been able to do that we haven't done it immediately. We've been able to, leave it for ages before they've had more Botox. Or some people have only needed one lot of Botox just to break the pattern of movement and get them.
And then you can get in and do all that desensitizing stuff that you were just talking about and getting that realignment. So really the Botox is just part of the story. And so I guess the message is to everybody out there is, if you're just having Botox and, you're missing an opportunity. The Botox is just part of it, and you need to be going to a physiotherapist, an occupational therapist, somebody who's really understands the dystonia, who can get in there and give you the therapy that is needed to prolong, to gain maximal benefit.
Absolutely, but it's all about teaching people how to manage it themselves. I have some clients who I've worked with for years. One of my clients, his presenting symptom was a foot dystonia. He still has it, but it's fine. It's well managed, and he has really regular input and stretches, and he likes to have some feedback on it from me because he wants to keep on top of it. But other people I've worked with, an early foot dystonia, which was really mild, never came back once we desensitized it and improved their movement, improved their balance, hasn't need to be looked at. And this is where I think the opportunity to really do some good work is potentially being missed, because we're so focused on let's get everybody active, and we're maybe not taking off their shoes and socks and having a look at them, or everyone just thinks it's normal. I don't know, for whatever reason,
let's just try and ignore that and push through it, kind of thing. And it's not about that. It's about let's really have a look.
Yeah, absolutely. And if it's not treated, it can really get worse. Whereas if it is treated, it can settle and be fine.
Yeah. what is the latest research? Is there anything, on the horizon that's kind of exciting you in this field?
I don't think there's particularly anything new. There are some amazing therapists that I've interviewed for my own research that are doing this as well, and have picked up on this. I did a big survey, and there are lots of people that have picked up that there are things going on in people's feet with Parkinson's, which was the focus of my study. But there are some fabulous therapists out there that are doing great work into dystonia. The other treatment that I haven't mentioned that can be really useful is functional electrical stimulation, FES. So some people will use that alongside, just in between things, to re-educate the movement. Again, I'm kind of thinking about feet in particular, but that's been really, really useful. And I've spoken to some good therapists that are using that. In terms of kind of coming through the research, the medical research is still talking about Botox. So we haven't really got the therapeutic research out there, not that I've read. And I think that's where I'm desperate to try and get my stuff in for publication.
And getting more work out there to answer these questions, I guess, for everybody, and also to improve therapists' knowledge. I think that's what's really important. I know Rachel and we've had discussions over this in the past. In our physiotherapy world, with the push, the emphasis has shifted, I think, on exercise and activity and getting people going and getting people moving. And that's all brilliant, because we know the evidence is strong on those neuroplastic changes that are happening in our brain as a result of exercising. But we feel as a physiotherapy profession that people aren't putting their hands, therapists aren't putting their hands on people with Parkinson's as much as they used to. And I know you've got some thoughts around that too.
Oh, absolutely. I just think maybe it's just the way things have gone in physiotherapy, or I don't know, that people are a bit less hands-on. Maybe it's the pandemic that means that people were like, oh, actually, we can do this remotely. But I've really looked at people with my therapeutic handling side of things, which I've used for years with people who've had strokes and other neurological conditions. And when I've looked at people with Parkinson's, I've just gone, oh, this is fascinating. And there's so much more we can do. So not, on all sorts of sides, we can look at, rigidity, we can look at elongation, we need to look at alignment to make sure joints are working effectively. And I think there is more that we can do. And I think there's lots of people out there that are actually doing it. We just don't jump up and down about it as much, because we're so excited about the exercise, which is exciting. It's fantastic. But I think there's other good news that we could look at as well.
And looking holistically at the whole person. We always go back to that, don't we? Vicky and I talk about that a lot. When you've met one person with Parkinson's, you really have only met one person with Parkinson's, and it's about looking at that person and thinking about them holistically in every problem.
Yeah, and it's really, for me, it's about giving people the tools to look after themselves, because part of that tools is knowing who it is they need to go and ask for advice for. But being the experts of themselves, I think, is just fabulous, because it's difficult. It's really difficult. I've not, it's difficult to have anything that isn't going to go away.
Yeah.
And we do acknowledge that as healthcare professionals, but that we need to be enablers and help people to look after themselves. I'm really passionate about that.
Yeah, no, totally. I totally agree with you on that front as well. And what about, we're talking about therapists, we're talking about empowering those individuals, but I think there's probably a role, isn't there, for family, friends, people with Parkinson's are living with, how can they help? What can they do for people with dystonia?
Absolutely. Just reassuring people that, it's okay. If someone has lots of excessive movements, then, helping them feel comfortable with being in and around other people, and, not making it weird, and trying to dispel that sense of, it's really abnormal. Or if I've worked with some amazing couples where their loved one is just so supportive, rather than kind of you're all tense and that's going to make that worse. They're just, let's stop and just take a deep breath, and really just wonderful, wonderful people who've been so supportive and been able to be nice in a really non-nagging, I call them loving reminders, but just absolute angels that will help somebody to just kind of go, I didn't realise I was getting het up. Thank you ever so much. Let's take a deep breath and just start that one again. And, I think it's amazing what people can do.
Yeah. And I guess it's having that knowledge, isn't it? Is again empowering the people with Parkinson's, but for the people with Parkinson's also to educate their friends and family or whoever, and their wider family, whoever they come in touch with, the general public. We go back to that, Vicky, we talk about that a lot, don't we? I guess one of the reasons why we do this is just, to be able to, get that knowledge out there, make sure that many people as possible understand this condition, and understand how they can support people and help people.
Yeah, it's really, really important to have that support and understanding. I mean, are there any resources or support groups for people suffering with dystonia, or practical tools that you would recommend possibly to those that might be listening?
There is a dystonia support group for people with dystonia, but I don't think there's a Parkinson's section on there.
Really?
At all,
That's
actually.
interesting.
Yeah, and in the movement disorders world, where you have all the other kind of Parkinson's related conditions, then dystonia comes up as a separate condition. But I don't think there's anything about dystonia on there. It's an opportunity, isn't it, for some of us?
Yeah.
Opportunity, but yeah. So I don't know of any other resources, to be honest. I know of a lot of therapy resources. If there are any therapists watching, there are various different people, or contact me or you guys about where to go. There's some very good therapists I follow in America that I find really useful. And so they're called Replus Active, and they're in California, and they have resources there. I think they might have resources for people who have dystonias. Again, there's that distinction between the Parkinson's dystonias and the generalized dystonias on their own.
Sure.
And I just don't think we get that definition, the distinction made well enough, really. Yeah, we need to look at it.
Yeah, no, fantastic. Well, it's an absolutely fascinating area. Do you know what? I've met so many people with Parkinson's that do have dystonias, and actually people that have them and, like you've said, don't recognize what they are, and have just thought it's part of their rigidity, which it isn't. That it's something separate that can be treated, and as you said, and something that can be done about that. So it's fascinating to have you here today, and to start this conversation. And I think by the sounds of things, there's lots more to come in this area, and there's with your publication and your continued work and interest in this area, I'm sure we're going to learn more and more about that, not only myself as a physiotherapist, but also Vicky as well, with living with your dystonia.
Yeah. And finally, Rachel, just thinking, there's so much going on with Parkinson's at the moment. What hopes do you have for the future of Parkinson's and dystonia care?
That people won't just accept it as something that's there, that they can't do anything about, but they will, know where to get good support for it, and people will signpost them and go, well, it isn't just a bit of Botox, but actually if you're going to have Botox, you could really do with seeing a therapist as well alongside to get the most out of it. That's what I'd like to see, and that people, that healthcare professionals understand it a bit more, because it is a complex area. Like there's the unmedicated, the medicated, it is complex. I spoke to a couple of years ago at a conference I was at, and was talking about my research and what I was writing and doing, and they were like, well, that's difficult. And it is a difficult area, so I understand that. But for me, it's like, if we look at people's feet effectively and help them, then it's going to help their balance, it's going to help delay any symptom progression. So I think it's really, really important.
Do you know, I agree. And also, I think dystonia is one of the things, we're specifically talking about Parkinson's, but it's embarrassing. It's the one thing in that, it's an ugly thing. It's not very nice. So it would massively improve people's lives. Definitely.
Yeah, for sure. I think it's I think it's brilliant, the work you're doing, and keep on. I look forward to reading your research once you have finish writing it when it's published, I look forward to reading that and learning more about dystonia. And I'm sure people will find this really fascinating. And as Rachel said, if there are
Absolutely.
anybody out there who wants more information, then please get in touch with us through the Shaking It Up podcast, and we can put you in touch with Rachel directly, and I'm sure she'd be happy to answer any questions that anybody has.
Yeah. Thank you to everyone listening. Thank you for joining us, for listening. I hope you found it of interest, and if you have found it useful, please do share it with anyone that you think might find it useful.
Well, thanks for having me, guys.
Great, we love you. Thank you.
Yeah, no, great. Thanks for your time today. And we'll look forward to seeing everybody very shortly.
Bye.
All right, take care.
Bye.
Bye.